have been present on admission, or even present before coming to the OR. So when we do have a hospital-acquired pressure injury that occurs, no matter what stage that injury becomes, we don't receive reimbursement for the care of that injury. So if that patient were to develop a stage 4 pressure injury that needed bone debridement, infectious disease involved for osteo, flap reconstruction by plastics, we do not get any of that money back, and that's probably something that you guys are familiar with already. But besides that, we don't want to cause harm to our patients, and we don't want to take the blame for something that just didn't occur here. So what we push for on the units is a 2-person skin assessment when a patient arrives onto a unit as an admission or is transferred to your unit from another unit. That involves 2 licensed people. That could be 2 RNs, it could be an RN and a provider, that will do a head-to-toe front-to-back skin assessment, hands-on and visual, on every patient on that unit. So a lot of times what we'll find with the OR is patient goes down, there's no report of a pressure injury, patient goes through surgery, goes to PACU, comes back up to the floor. 2 days later we find a deep tissue injury. So it's like, okay, did this occur in the OR or did this occur on the floor? And it's not a blaming exercise. That's not the point of this. The point of this is to determine if there are processes in place or a lack of process in place that needs to be revised so that we can help prevent injury to the patient. So what's really important for you all in your area is for 2 of you, and I know how hard that can be in the rush of getting patients prepped for surgery, to have 2 of you do an assessment on a patient. What helps with that is 4 eyeballs on the patient so you can catch something that someone else missed. The other helpful thing about that is with staging. We have a lot of knowledge deficit with staging of wounds, so one of you might be a little bit stronger in that respect than the other and can help appropriately stage a wound. Because as of last year, the new ruling is if you have a stage 2 pressure injury that deteriorates to a stage 3 pressure injury, that becomes hospital acquired. And that was not the case previously. So we want to make sure that we're staging wounds accurately, and if you ever have questions about that, you are welcome to reach out to Wound Care, and we are happy to help with that. So, I'm going to let Patrick talk just briefly. We'll start about what is a pressure injury and kind of get into the science of that a little bit.
Just a little bit. So, hopefully, I think a lot of you guys probably have some experience at the bedside at some point. So, you're familiar with what pressure injuries look like and what they are, but just to kind of give you a better idea of what exactly a pressure injury is, these are the highlights. Sorry, I'm going to take my mask off because I can't talk. Basically, these are the highlights right here. The first and foremost is the majority of them occur over a bony prominence, like the tailbone, or like an elbow or a heel. Those are the kind of common places that you're looking for. They could be under a medical device. If you've got a patient that's intubated, they could get one on the lip. If they've got an NG tube, it could be in the nose. Those are the kinds of things we want you guys to be kind of taking a look for or looking out for. They can be intact versus open. So if you see something that's kind of red and non-blanching, then that's especially if it's over a bony prominence, then chances are that might be a pressure injury that we've got to look at. And again, pressure injuries can occur because of short-term, high-intensity pressure, over a short period of time, or it can be because you've got steady pressure. It just kind of sits there for hours and hours and hours. And if you think about patients going to the OR, if their heel is not properly offloaded, it's just sitting on that hard surface for 5, 6, 7, 8, 9, 10 hours and not being relieved, that might be all it takes to give that person a pressure injury.
And just on that note, I wanted to add that even though when we look at some of these surfaces and they are pressure redistributing foam or they're gel or even a low air loss mattress, that is really not enough to prevent injury. That does help redistribute pressure so that it's not all on that one focal point, but we still have to exercise proper offloading when it's possible. The OR is tricky, we know that, but exercise proper offloading and turning so that we can alleviate some of that pressure to that bony prominence.
And to give you a really good example, if you think about your heel, right? You've got one tiny little artery that perfuses that heel, right? That peroneal artery perfuses that heel, and there's a term called capillary closing pressure, and it's basically how much pressure it takes just to kind of close off a capillary, and it's not much. I mean, normal capillary closing pressure is, I think, 16 to 30 millimeters of mercury or something like that. It's not much. But imagine if you got a patient that's on pressure, elderly, with peripheral vascular disease, with diabetes and everything else, that capillary closing pressure is nothing. So, you know, just having that heel fit on the bed or on that hard OR table for half an hour maybe, that's all it takes. So, just something to think about. So, the other point, if you look at the second page about pressure injuries being cumulative, so pressure comes from not only the pressure itself, but it also comes from shear force, right? A lot of the new research is talking about how shear force is more important in the formation of pressure injuries than the actual pressure itself. You know, just the shearing and the tissue deformation can kill those cells faster than pressure and ischemia by itself, okay? So the fact that pressure injuries are more cumulative in nature, you know, the example is right here, patient goes to the OR for an extended period of time, then goes to the PACU and is not turned for a couple of hours, then goes to the ICU and they elevate them out of the bed, but the patient is not quite stable, so they don't turn them that much. All of those kind of insults to that tissue kind of add up to long-term and lasting damage. So those little red circles, everybody knows what the hot spots are. You know, it's the back of the head, it's the heel, it's the sacrum, any kind of the sharp bony prominences. Risk factors, we all know what the risk factors are for pressure injury. You know, the ones that are super at risk are going to be the very elderly with peripheral vascular disease, the hypertension, the diabetes, all of those things are going to add up. Now, skin assessment. Elisa, you want to kind of talk about skin assessment?
So with skin assessment, and you guys I think are fortunate to be in an area where you have good lighting. Sorry, I don't know if you need one. Where you have good lighting. If you work in North Hospital, not the case. North Hospital has the worst lighting in America. But here you've got these nice bright lights. So you should be doing a good thorough skin assessment that's hands-on. So you're starting at the top of the head, you're feeling around on that occiput, looking behind the ears, making your way down, looking at scapula. You're looking at front, your anterior iliac crest, you're looking at sacrum, coccyx, looking at knees, ankles, toes, in between toes. I know that sounds very time consuming, but once you start doing this assessment, it's just ingrained in your practice and it takes just a few minutes. And again, what's helpful in having a second person do this with you is one of you might be, again, more knowledgeable with staging or recognition of pressure. And additionally, you have 4 eyes on that patient, so it can only help the situation. But I cannot stress enough the tactile portion of that inspection. Our floors have missed a ton of pressure injuries on the occiput when you've got patients with nice, thick, dark, beautiful hair. You may not see that boggy or indurated skin or tissue, and then 2 days later you have a giant unstageable pressure injury that's Eshard, and that's a problem. So had we seen that or recognized that earlier, we could have done some appropriate offloading and sort of started to reverse the effects of that injury. So the hands-on piece is so very important. We're looking under medical devices. So we're looking under nasal cannulas if they come down with that. I don't think patients come down with STD hose, but these are the things we talk about on the floor, looking under socks, looking under STD hose. We want to document anything that we find that's abnormal. So my question to you all, when you're in the pre-operative area, are you documenting in Cerner or Surgenet? How does that work with you guys?
It's all Cerner now, isn't it?
It's all Cerner.
Yeah,
Okay.
it's all
Surgenet has gone away.
I did not know that. That's great to know, though. Okay. So there's a piece on the next page. Actually, I'm going to skip ahead. So it's at the bottom of the 5th page. I'm sure that at some point in your nursing career here, if you're not already doing it here, documenting a skin assessment, an IU, and Cerner, you're gonna make a notation of anything that you find is abnormal. So whether or not you think it's pressure, if there's something abnormal in that skin that's not already has a band created for it, and you should create one. If something's charted as a wound and we determine later that it's pressure, okay, great, but we can always go back and look at that time and date stamp to realize that wound was present when the patient came to the OR, when they came to the facility. All right, going back a little bit, back to
Let me
page.
add one more thing. As far as documentation, if you don't know what stage a particular wound is, like if you see something that you think is probably pressure, but you don't know what the stage is, at least document what it looks like. Tell us that it's got yellow tissue in the wound bed. Tell us that it's you know, black or purple or red or whatever color it is. Give us an idea of how big it is. Is it quarter size? Is it, you know, roughly 4 centimeters by 5 centimeters? I mean, anything like that that can kind of give us a clue as to what it could be. And if you don't want to put it under pressure, put it under wound. And like Elisa said, if we've got that documentation, then we can go back and go, that was probably pressure, and make sure that you're documenting the anatomical location, because sometimes we'll get something weird like, you know, posterior heel or something weird. It just doesn't make sense. And document right heel versus left heel. You know, those are very important kinds of things. Okay?
And just sort of piggybacking off of that, there was a time when some of our deep tissue injuries, which have the potential to be our worst injuries, were being documented as stage 1. So the patient would come in from the field, whatever, we document a stage 1 on the sacrum, well then 2-3 days later, you've got a giant unstageable pressure injury, and it looks again like it got worse on our watch, when in reality, that was likely a deep tissue injury on admission, misstaged, it, as part of the progression, became an unstageable, and unfortunately not documented appropriately because of happy. So, noting the color of a wound is really important. This slide right here on page 4, when we talk about where to look, I always sort of say, I don't really care if the patient's bed bound or chair bound, every patient should get the same assessment. And your walkie-talkie compliant patients, those should get the same head-to-toe thorough assessment. It'll just be easier for you because they can help turn in all sorts of things. But we can't assume that our walkie-talkie independent patients do not have pressure injuries. Those are the ones that end up with pressure injuries on the heel from sitting up in the chair too long or the recliner, or having their legs crossed, or knowing that they can turn but they're not turning. They end up with a sacral pressure injury, so they need that assessment. We do educate the floors as well that the patient has been in the OR for an extended period of time. So for us, we say 3 hours or greater puts them at more risk for pressure injury. If your patient has been in the OR, you're doing a thorough assessment every day once that patient has come back from surgery, just to make sure you don't see any deep tissue injuries forming. And again, not a blaming exercise, but a point for us to say, okay, maybe you guys need some more surfaces or different surfaces, maybe you need a different foam. So it really is helpful for all of us and for the patients. When you have patients with darker skin, these injuries can be a little more challenging to recognize. So again, that's where your hands-on assessment comes into play. When you're feeling on a sacrum that doesn't look the typical red or purple, maybe it looks a little gray or a little bluish or just a little darker in color, and that patient's wincing, they're telling you it's painful, it feels foggy or indurated, that's probably the start of a pressure injury. So those are the things that we would want you to note in the chart.
And also think about temperature too. Like if it's a deep tissue injury, if it's an acute deep tissue injury, you know, does everybody know what indurated means? Indurated means firm, kind of harder, or maybe slightly swollen. But if you feel temperature changes, like if you are palpating over the sacrum and it's kind of firm and you can't really see any kind of, like it might look a little bit darker, but you feel it and it feels hotter or warmer than the surrounding skin, that probably means that something's going on there, okay? So think about temperature, warm versus cool, that sort of thing.
Yeah, so sort of texture or feel, temperature and color, all very important. So performing the skin assessment, we've already covered that. This just kind of highlights the 2-person skin assessment. You have to make a comment somewhere in iView that you had a second verifier. So a lot of times on the floor, if it's the admission assessment, they'll just right click and type in the second nurse's name. You can also do that in iView under pressure ulcer comment. You can note that a second person was the verifier. All right, so this is at least one of my favorite parts, talking about dressings. And I wish that we had some pictures to show us. Mephilex sacrum, Mephilex heel. These are fabulous dressings and work very well when they're applied correctly. So a couple of things about both of these dressings. They are ridiculously expensive, but there's so much science behind them to support what they do in the way of preventing pressure injuries. There's the 5-layer foam, silicone base, so it's not going to damage the skin when you remove it. That 5-layer foam helps prevent friction and shear injury. It helps to also redistribute pressure, so it's not all on one focal point of the coccyx or the sacrum. And it does not impair your microclimate. Microclimate is a fancy way of saying moisture on the skin. So this is kind of wicking that moisture away and not holding that moisture right against the skin. Now, these can stay in place for 3 days. Unless they're soiled with stool or wound drainage, then they need to be changed more frequently. Heel dressing works the same way, but in order for them to work properly, they have to be placed properly. We have several pictures in our office that are really entertaining, where people have put these dressings on when the patients are sitting up the side of the bed, and we've got a guy walking down a rehab with this up here. That is not protecting the sacrum or the coccyx in any way.
I've got one right there.
That's a heel where literally everything is covered except for the heel.
Oh no.
Everything's covered but the heel.
And yes, so Mephilex sacrum. We actually have had patients that have sustained pressure injuries where breasts have pushed against one another, where butt cheeks have pushed against one another. So this must be pinched into the gluteal cleft. Spread your buttocks apart, pinch this into the gluteal cleft, and then apply your dressing. Now, I'd say 9 times out of 10, you'll see us flip this upside down, and that's okay as long as you're covering and encompassing that coccyx. This tail gets down into that gluteal cleft, which is a wet space, and if the patient's incontinent, it kind of destroys your dressing. So you are actually fine. Flip this upside down, pull it down low enough where it will encompass the coccyx, spread your buttocks apart, put it in there, and then put the dressing on. Okay? And you've got a good visual of that in your paper. The heel, maybe not quite as intuitive, but when you put this on, you want the larger wings up here at the top, because that's going to encompass your ankle bones, right? Your malleoli. So you want to put the heel here. Use these top portions to cover the ankles. Use the bottom portion to cover the plantar surface of the foot. Now, if you do it in that order, where you put the top one first, pull this up around and secure it, when the nurses on the floor go to do an assessment, they can pull that back, take a look at the heel, and put it right back in place without destroying the dressing. Now, every now and again, this border gets a little funky and crimpled and kind of rolled up, and that's okay. As long as the dressing can stay in place, the foam is really the most important part of the dressing. But if you do it that way, it can help salvage your dressing. All right. Do you guys have any questions about assessments, about dressing application? I know, how often do you guys put either of these on? Every day. So the patients, same-day surgery obviously are not coming with this, but hopefully on the floor, or a lot of patients coming over with this on first. Okay. This dressing, and I'm not sure that you guys have this readily available down here, so I know Cardiothoracic had mentioned that they were going to start putting this on all of their patients, which is great. Those patients obviously already have some vascular compromise. They're going to have that lower capillary closing pressure. So great for that population. I would say that if you guys do have patients that are going to be in surgery in a supine position, for example, for an extended period of time, if you're able to apply these, it certainly will not hurt. You guys do use a lot of foam to elevate limbs and things like that, correct?
The OR, yes.
The OR, okay, all right. All right, but if you have access to these and you have a patient that's going to be in surgery, like I said, 3+ hours, not a bad idea to go ahead and put these on.
We don't have the heel one, but we definitely have the
We do.
sacrum. We used to.
know if we still do these.
I can check.
We used to have the heel ones in the corner.
One thing I'll say, and I just, this has been an issue, previously with some different surgical services. To recognize that Mepilex Border is obviously not the same thing as Mepilex Light. Mepilex Light is a thin foam dressing that you can cut to cover the size of the wound. It's got some absorbency, but it does nothing in the way of pressure and redistribution prevention. These dressings also, whether it's this size or the small square dressings, if you cut them, you might still get the absorbency and you'll get the silicone backing that won't damage the skin, but it will no longer redistribute pressure because you've compromised the dressing. So, just something else to know.
Question?
Yes. When you said a pressure also underway, so is that something that we should consult with you? Because if we're not sure if it's a stage 1, stage 2, or is deep tissue turning, maybe turning into something else, what?
You can, we are always available for questions. If you guys want us to lay eyes on something, if time is of the essence and you guys are trying to get a patient through here, if you even describe an IVO, okay, there's purple discoloration to the right heel, you could even chart it under pressure ulcer, and make a note again, color, drainage, if there's dead tissue in the wound bed, the patient goes to surgery, they come back to the floor. What you guys would want to know, if you actually choose a stage, wound care will get a consult for anything that's noted as a 3, a 4, an unstageable, or deep tissue injury in IVU. So if you chart a 3, we're going to get consult printed to our office. When that patient gets back to the floor, we'll go and see them. Now, if you're just charting the appearance of the wound, we may not get that consult, but when that patient gets back to the floor, hopefully that nurse is going to alert us to it so that we can come and take a look at it, especially if you're charting it in the pressure ulcer band.
And then we'll know that you guys saw it first,
Right.
and we can take that into consideration. Any other questions?
I did check. We have 4 containers of actual sacral
Okay.
Mepilex in different sizes, but I'm going to talk to the manager of this unit and see if we could change out one of those or add the par for heels.
Can you make
I
sure
don't think we need 4 of
If you
those.
guys just go ahead and stock the large ones and not the small ones.
The baby ones are really only useful for peds. I mean, even if you had a frail little old lady, I'd still put that large one on there.
Let's get better coverage.
Yeah.
Thank you.
Of course. Any other questions?
Good?
Thank you guys. Thank you.
Thank
No
you.
problem.
Thank
No
you.
problem.
Patrick, I appreciate
If you need
it.
them, no problem.
Thank
If you
you.
ever need us for any discussion, education, just call. We're happy
Thank
to
you
do
so
it.
much.
Do you have a pager number?
Yes. 4325. But if you look me up in Tell Page, I'm there.
Okay. Thank you.
If you even just type in wound care,
Mhm.
it'll list every wound care
All
team
of us
member
come up.
and who's on that day, so you can page any of us.
Awesome. Thank you.
Thank you so much.
Thank you.
Thank
Good job. Have a
you.
good one.